All right, next up we have Dr. Darshan Trivedi. He's our neuropathologist at Ochsner, and he is going to be talking about DNA methylation profiling and classification of new CNS tumor entities.
Good morning, everybody. Thank you, Dr. Golden, for inviting me to speak today. My name is Darshan Trivedi. What is it that a pathologist does? We are the diagnostic physicians of the hospital. So this is talk about one of the tools that has recently emerged, helping us in those diagnostic protocols. No financial disclosures. So what is DNA methylation profiling? It was first introduced in 2018 by an absolutely phenomenal work group at the University of Heidelberg, Germany. They published a paper in Nature showing that they had developed a classifier system using DNA methylation analysis to aid in the diagnosis of CNS tumors. The initial classifier contained about 82 tumor classes with about non-neoplastic control tissue types. And the most recent version published last year is version 12.8, and that has greatly expanded to about 184 classes. Our most recent publication of our guidelines published by the WHO was published in 2021, and even just 3 years after the publication of the Heidelberg paper, the WHO has characterized this platform as essential or desirable for the diagnosis of multiple tumor types. General principles. So based on the observation that patterns of DNA methylation across the genome are correlated with the tumor type in a reproducible manner, epigenetic changes occurring because of specific genomic alterations can also influence the DNA methylation profile of a neoplasm. And comparison of the findings to a reference set, which is the classifier I was just talking about, of the defined methylation classes, the closest match can be determined along with a confidence score. How this is done? Well, a lot of this is proprietary, so I can't really speak about it. But really what they're using is a methylation bead chip produced by the private sector. That bead chip contains about 450,000 interrogated CBG sites attached to both a methylated bead and an unmethylated bead. If the tumor site is methylated, transcription will proceed forward at that site. If the tumor site is unmethylated, transcription will proceed forward at that site with the unmethylated bead. So, simple as that. That is all of that data is then fed into a machine learning algorithm using that classifier data set, using iterative regression analysis. That data is then matched to the data within the classifier set, and a confidence score based on that information is developed. So what does that output kind of look like? So this is a classic kind of tumor example that we often use to stump pathology trainees and people taking their boards. So at low power, we're seeing a very, very hypercellular busy neoplasm. That's the top image right there. On the bottom image is a much more high-power zoomed-in image, and we can see a lot of very ugly cells that really shouldn't be there in the brain. Now, a quick look says, okay, ugly cells, this must be something aggressive, malignant, high-grade. But to the trained eye, what we are not seeing is actually necrosis, microvascular proliferation, mitotic activity, the things that would be characteristic of a malignant neoplasm. So somebody was stumped by this. They sent it to a facility that does DNA methylation profiling, said, help us out with this. Let's see if we can get some more data to try to figure out what the proper diagnosis would be to inform people like Dr. Golden about what the proper treatment protocol should be. So the facility they sent this to, one was the National Cancer Institute at Bethesda. The other is DKFZ, which is the facility at Heidelberg, Germany. They're using both of their classifier data sets. And the answer that came out is a pleomorphic xanthoastrocytoma. Now, even though this is a very ugly-looking tumor, a pleomorphic xanthoastrocytoma is actually a very low-grade tumor, and surgical resection is often curative without the need for additional chemotherapy and radiation. So that's what this whole platform is there to inform people about, is do we need to be aggressive in the therapies of these patients? Do we need to be not so aggressive in the therapies of those patients? You can see the confidence score on the rightmost side, and that is 0.99, which is as high as it goes. So very, very high confidence about this diagnosis. On the bottom plots, you can see a copy number variant plot showing the entire genome graphed across this plot. And you can, in particular, and maybe you could see, is there a cursor or pointer? Pointer? Chromosome number 7, right there, all right? The characteristic mutation of pleomorphic xanthoastrocytoma is the BRAF gene. So that's located at chromosome number 7, so that's what that's picking up right there. Also, a number of other variants are there as well. So then you take all of that multivariate data, you use a UMAP, which is a universal manifold association plot, I believe is the correct explanation for that abbreviation. And that, using the machine learning algorithm, will plot it smack dab right in the group that are the pleomorphic xanthoastrocytomas, according to those classifier data sets. So very, very high confidence that this is the diagnosis that needs to be made. Here's another example from kind of the opposite end of the spectrum. Here again, we're seeing very, very hypercellular tumor at the top image. At the lower image, we are seeing these tumor cells kind of gathering around these blood vessels that are very, very tiny in caliber, but seem to have a lot of kind of acellular material aggregated around them. And then if you look back at the higher power image, you can notice that there's a lot of discohesion between the tumor islands that are aggregating around those blood vessels. So very, very interesting looking tumor, not really definitive appearance for anything really. So they do their analysis, and again, same exact spot, we're seeing a lot of alterations in busyness at chromosome number 7, but we're also seeing a lot of point mutations and deletions all throughout the genome, as well as some elevated copy number changes. Interestingly enough, when plotted, this comes out with the answer CNS tumor with B-core and B-core L1 fusion alterations. Now, this is the interesting part about this platform. B-core and B-core L1 are X chromosome-based genes. Look at the X chromosome all the way at the end of that CNV plot. Are you seeing any alterations there? No. So this platform is not picking up the characteristic alteration that would be associated with this diagnosis. What it is picking up is all the other associated methylation alterations that would commonly be seen in this tumor. So when they grafted onto you did their machine learning analysis and then grafted on to the UMAP plot, the answer they got is that this is consistent with a CNS tumor with B-core, B-core L1 fusion, even though the genetic analysis is not actually showing that characteristic molecular alteration. Yes.
It's not, they don't detect the lesions here, so that's not because of
It's not, so that would be what you would use NGS for. Right, you would use NGS to pick up those alterations. This would be in addition to that NGS analysis.
We want to get the B-core, B-core L1 fusions in. I think it's better to get the RNA sequencing rather than just methylation.
Exactly, and any institute that does the DNA methylation profiling will also do RNA sequencing in addition to that to provide additional data. So, very good question, thank you. So if you look at the confidence score then, according to the Bethesda database, this is a 0.81 score, and the Heidelberg database is actually showing a high confidence score with this, just based on that methylation profile. So let's just go through a couple examples of what this will output. So I perform my histologic analysis. I'm seeing a low-grade tumor, very characteristic for an oligodendroglioma, which is a low-grade infiltrating glial neoplasm. I'm not seeing any high-grade features. I do the NGS analysis. TERT promoter mutation is something that is very scary and something that jumps out at us as a characteristic for a high-grade mutation. But when seen in combination with an IDH1 mutation, that is very characteristic for an oligodendroglioma. So again, a very low-grade tumor. We do the chromosomal analysis. We see the characteristic chromosomal alteration for an oligodendroglioma, 1p19q full arm co-deletion. So all of that data gives us that diagnosis. Now we are testing the DNA methylation profile and the classifier databases against what we know to be true. So this is much more of a kind of a positive control kind of situation, okay? The family is kind of the broad spectrum classification. So this lands in the family of diffuse glioma, IDH mutant. The confidence score is 0.99, and the class designation is oligodendroglioma with all the rest of it in there, also 0.98, pretty high. So again, this is a positive correlation, and we have a grade 2 glioma. So the NIH actually, the WHO actually suggests us to list all of this out in our diagnostic reports. I try to take it easy on my oncologists and neurosurgeons and make it a little bit simpler than that. Here's another example of the opposite thing. So in this case, we are histologically seeing a high-grade infiltrative glioma. The most common high-grade infiltrative glioma, glioblastoma, most common tumor we encounter. Okay. I do the NGS analysis, TERT promoter mutation by itself, characteristic for glioblastoma. Chromosomal analysis shows gain of chromosome 7, loss of chromosome 10, also very characteristic of a glioblastoma. But when you put it into this DNA methylation profiling database, no matches are found at their level of significance. What is their level of significance? They want it to be at 0.9. Why they chose that number, I do not know. But that's the level that they have established for their confidence interval. So in this case, no high confidence match is found in the family and no high confidence match is found in the class. So based on histology, based on molecular profiling, we have a glioblastoma. Based on DNA methylation profiling, we do not have a match, but we should proceed forward with the data we have. Okay. This is a very characteristic stumbling block. In many pediatric tumors, we do not have a good name for a lot of what happens. A lot of them are very heterogeneous. They have mutations, but they do not have classic histologic appearances. They have classic histologic appearances, but they do not have classic mutations. In many cases, they have neither of those things. So in this situation, we have a low-grade glial or glial neuronal tumor. It shows an FGFR1 mutation, but it shows no chromosomal alterations. The DNA methylation profiling really can only establish that, yes, this is a low-grade glioneuronal tumor, but it cannot further specify based on the methylation spectrum of this tumor. And finally, what happens when we encounter something that is truly bizarre and unique? So in this stage, we have a glioneuronal tumor, likely from an adult case. It shows a very, very peculiar NTRK2 mutation, but fusion rather, but we don't really have that characterized within our WHO classification. There are no chromosomal alterations. We have a diffuse glioneuronal tumor, non-defined type, as our confidence score. And the Heidelberg database puts out a glioneuronal tumor, kinase fused, with a strong confidence score, but there is no real name for it, and when you look through the classification of the WHO, there is nothing that matches this. So this is truly a new tumor type discovered by this DNA methylation profiling. So what are overall the limitations for this? Well, there's an issue with content of tumor within the sample produced. This is a very tissue-intensive process, especially since you would probably need to do NGS and, as you stated, RNA sequencing and multiple other platforms as well. If you submit a sample, say from the periphery of what is classically a glioblastoma, you can get very, very weird outputs because they haven't had the full epigenetic expression of the truly high-grade areas of that tumor within the more lower-grade areas of that tumor. So what is, in all other sense, a glioblastoma could be outputted as a ganglioglioma, which makes no sense and you can't do anything with. A substantial number of cases result in low confidence matches. So as you saw, if it falls below that 0.9 confidence score, what do you actually do with that information? Is it truly a match for that case, or is it something more suggestive of a tumor leading towards that case? Low-grade glioneuronal tumors can be ambiguous, as we saw in that example. There are not a lot of well-defined tumors. Things that are well-defined histologically, such as pilocytic astrocytoma, ganglioglioma, all of these low-grade tumors tend to bunch together a lot within this machine learning algorithm. And one interesting thing, which is a little anecdotal story I have for you, is that a patient, which is the pictures on the right, was about an 80-year-old lady with a sinonasal tumor originating from the skull base, very high-grade in appearance, very ugly looking. Because the surgeon who did this operation was a neurosurgeon, the tissue went to a neuropathologist. The neuropathologist could not figure out what it was, so he sent it for DNA methylation profiling. And what that DNA methylation profiling picked up was a SMARB1 or a SMARCA4 deficient tumor. Now, in the neuropathology context, if you say that, if you're studying for your boards, you say that mutation, there is only one diagnosis that comes up: atypical teratoid rhabdoid tumor. What's wrong with that answer? An atypical teratoid rhabdoid tumor does not occur in the skull base and extend into the sinuses. It occurs in the posterior fossa, a completely different location. It does not occur in 80-year-old women. It occurs in children, usually under the age of 10. So how can it possibly be an atypical teratoid rhabdoid tumor if none of the other demographic or histologic or other suggestive data points towards that? That mutation is so heavily weighted within the machine learning algorithm that that is the only answer it can give you. And keep in mind that this DNA methylation profiling is really to date only being used in neuro-oncology. What that answer was is an INI1 deficient sinonasal tumor. It just happens to have the same mutation as an ATRT. If you do head and neck pathology as I do, that would be the obvious answer. So what are the recommendations? DNA methylation profiling should be considered when a differential diagnosis needs to be resolved to inform clinical care. The WHO lists several tumor types where DNA methylation profiling is considered desirable or essential, and results should always be interpreted in the context of all additional histologic, immunohistochemical, and sequencing information. Where do you send this? There are two institutions available right now to us. The first is the National Cancer Institute, associated with the NIH in Bethesda. This is a free service. It's paid for by your taxpayer dollars. It has the largest available clinical database. They have a tremendously high volume, so it will take about a month or two. So if time is of the essence, this is not what you should send it for. The problems is that, A, they cannot really provide you a grading. You have to do that with histologic and immunohistochemical analysis. It is very tissue intensive, and because this is a government agency, it is very much beholden to what is going on in the government at the moment. I did send a case last November for DNA methylation profiling, and the very next day is the day the government shut down. So I had to wait 3 months for the answer to come back. St. Jude's Children's Research Hospital is an excellent facility. They also provide free services. They will turn it around within about a month, and they have a tremendous amount of experience using very, very limited amount of tissue. So excellent facility. The only limitation is the patient has to be under 19 years of age. That's it. You cannot send an adult patient to St. Jude's. So what do you do with all this information? There's the classic diagnostic peril between lumpers and splitters. Splitters want to drill down to the minutia of every molecular feature and create a new tumor entity for every single one of those features. Lumpers want to aggregate all of that data together to provide the most clear answer for our clinical colleagues such that they can move forward with the patient's treatment. Literature, unfortunately, has a clear splitter bias. It's very easy to publish that, oh, I'm finding this unique little change right here, unique little change right here. This should be a new tumor, and you should name it after me. Subclassification should be based on prognostic and predictive significance. Okay? Our CE Impact now, which is our kind of guiding wizened elder community within neuropathology, has decided that they needed to step in and actually rein in some of this behavior. So what they've established is that you should have clear prognosis and expected responses before you can declare a new tumor entity. They should have unique clustering patterns and profiling. The associated molecular profile should be comprised of either a distinct single or combination of genetic drivers, and the associated microscopic features should be very typical or at least reproducible in these situations. So in conclusion, this is a new technology. A lot of data is being generated by it, and it offers the opportunity to further refine and classify all of this information that we are gathering now. But we have to understand the capabilities and limitations of that platform in order to properly assess the information it outputs. And complexity should never outpace clinical utility. Everything I said in this talk is based on these two papers. Ken Aldape is largely the American scientist and neuropathologist driving a lot of these innovations. He's since moved from the NIH to the Mayo Clinic. And the C-Impact Now 10 is the recommendations for new tumor classifications. And that is it. Thank you very much.
How can you confirm that smart V1 presentation defect is caused by tumor? As you mentioned, that tumor presentation is unusual, but considering all kinds of clinical features and the location-wise. Now, only presentation defect will pass, but have you seen the sequencing or mRNA level or protein level to confirm that this is actually causing a problem?
Yes, you would have to verify all of this with sequencing. So the first step to do would be sequence the tumor. If you see characteristic molecular profile within that sequencing, then you don't really need DNA methylation profiling. If that is somewhat heterogeneous, not contributory, or otherwise generating kind of an ambiguous answer, which it does many times, then you can proceed forward with DNA methylation profiling in hope that, that methylation profile might provide a better answer.
Not all the time, the sequencing defect is causing methylation issue. For example, like RD1A in uterine carcinoma, even though they have a mutation, they are not actually causing methylation problem. And then NH3A as well, even though they have mutations, not always they are causing a methylation defect or mRNA expression. But if the sequencing, even though sequencing is normal, I think we should go to the next step, like mRNA or like protein level to see actually the protein is not growing.
No, that's very good insight.
Why is it? In the clinical period, it is just showing the methylation defect, and then the clinical phenotype is not matched exactly with this model we want. It's hard to say that this is it until we prove the protein or like other requirements.
All right, thank you very much, Jeff.